We're going to shift gears a little bit, pivot a little bit away from fundamental biology. We just heard some wonderful talks about the sort of lab bench biology, discovery science that's happening, and shift into novel findings in clinical practice with Dr. Brian Cuthbertson. Dr. Cuthbertson is an attending physician and former chief of the Department of Critical Care Medicine at Sunnybrook Health Sciences Center. He's a professor in the University Department of Anesthesiology and Pain Medicine, as well as the Interdepartmental Division of Critical Care Medicine at the University of Toronto, and the Vice Chair Research in the University Department of Anesthesiology and Pain Medicine. This morning, he's going to tell us all about an innovative way to improve outcomes from critical illness whilst reducing antibiotic resistance.
Thanks very much. It's an absolute pleasure to be here. That title is designed to intrigue you. Breaking news, folks. Wonder treatment reduces the risk of death from critical illness by 9%. Effectiveness from massive RCT shows this benefit. Meta-analysis supporting that strongly. Massive, a 28% relative risk reduction in bloodstream infections. A 10% reduction in ARO carriage. Reducing therapeutic antibiotic use. This is a gift to you. It's a new tool that I'm giving you to fight antibiotic resistance. Now, if I told you that I was going to be speaking about SDD at the beginning, I'd be about as welcome as a fart in a spacesuit. But that's what I'm here to talk about, the SuDDICU trial. I'm not going to tell you about hospital-acquired infections. SDD's been around since before I've been in medicine. It's not in the slightest bit sexy. Large RCTs only more recently, but about 38 RCTs on this topic and about 14 meta-analyses. That's more meta-analyses than there are trials in most areas. It's decontamination of the digestive tract, not sterilization. It's about killing off aerobes, gram-negative aerobes, not anaerobes, and fungi in the gut in an attempt to prevent the hospital-acquired infections that we know so well about. Let me get the terminology right. These are gut decontamination strategies. SOD is just the oral and enteral antibiotics. SDD is that with an IV antibiotic, usually a cephalosporin. The evidence base before the SuDDICU trial was from 36 RCTs and 11 meta-analyses by then, showing a very significant reduction in mortality, a massive reduction in ventilator-associated pneumonia, but nobody did it. We wanted to look at this and understand why. So we started a collaboration many years ago. This has been going for 17 years now, and we've just completed the RCT. You maybe saw it in the New England Journal 2-3 weeks ago. It's been led internationally across Australia, UK, New Zealand, and Canada. Phase 1 of the trial, we said there wasn't enough meta-analyses in this topic. So we did the 12th at that stage. We showed the same results. We also showed that chlorhexidine was harmful, and then we did a 3,200 patient trial that showed indeed it was no benefit, and we took it out of practice, I think, in many and most units, the CORAL trial. The evidence for the ecological impact, because that's what you're all worried about, giving antibiotics to people and causing resistance. And I managed to get Nick Danneman to come over to the dark side and join us here. I think you've all hated him ever since. Well, maybe until he produced that trial last year, perhaps. But showing that, in fact, resistance to all types of antibiotics was reduced by giving SDD. Indeed, for all the components, it was reduced. And you gave less antibiotics. Sorry, I jumped past there. You gave less antibiotics most of the time. So with phase 2, we said, what is SDD? How do we give SDD? Do people care about SDD? Whether we should do SDD? Whether it's appropriate to do SDD ethically. And we asked all you lovely ID people what you thought about this. Canadian infectious disease doctors are the nicest people in the world. And this person told me to adopt SDD in my unit, someone would have to assassinate me. So we did. Phase 3 was our pilot studies, and phase 4, 5, 6 is the RCT. We hypothesized that SDD would reduce mortality and not harm ecological resistance. in a multi-centered cluster crossover randomized controlled trial with a very large cohort of ecology to look at the effect of antibiotic resistance. We randomized patients, a cluster, should I say, hospitals, ICUs, and then we crossed them over, we washed out between, and we measured the antibiotic resistance before, during, and after, as you can see from this diagram. The main outcomes were primary outcome was mortality, but I believe really as a co-primary antibiotic resistance because it's just as important, possibly more so. We looked at days alive and free of ICU ventilation and hospitals. We looked at infectious outcomes such as antibiotic use, ARO rates in sterile cultures, non-sterile cultures, C. diff, etc. And we included mechanically ventilated patients. We thought were going to be ventilated for 48 hours. We excluded very few patients indeed. The intervention was almost good old-fashioned SDD. That's colistin, tobramycin, and nystatin. It used to be amphotericin, along now with the intravenous course for 4 days. So the topical and oral for the duration of mechanical ventilation, the IV for 4 days. We needed 9,000 patients in the trial to do this. We did not power the ecology part of this study, but we thought we'd get up to 20,000 patients. Our baseline data shows that, and indeed, we recruited a huge amount of patients before, during, and after all these stages. And as you follow through, you'll see that in the first period, it's about 2,500 in each group. We washed out. All the centers crossed over. We got another 4,000, 2,000 approximately in each group. And we ended up with 9,400 patients in the RCT and 10,700 patients in the cohort trial. The baseline shows the numbers there, and that they were about 60. They were from the ER and from the OR and other such places, similar to many ICUs. They were given the treatment within about 10 hours. Baseline-wise, they were moderately sick. That's a predicted mortality of about 30%. Moderately immunocompromised, and indeed, about 2/3 were getting therapeutic antibiotics at the time of arrival in intensive care. The ecology patients, 10,700, were slightly the same age, but slightly less sick because it included non-ventilated patients in the same unit. So remember, the ecology are people who are also in the unit at the same time, but not getting SDD. And they had a lower mortality because they were a less sick group. When we look at the IV antibiotic usage total, it's about the same, but therapeutic use is reduced with SDD, including the SDD intervention. We gave less therapeutic antibiotics. There's the defined daily doses. Our compliance was over 90% initially, but it did dip a little with time. Patients don't like the stuff in their mouth very much. Over 90% of the intervention group got the IV, but remember, about 60+% of the control group were getting therapeutic IV antibiotics. There's a small reduction in the use of cephalosporins and penicillins in the SDD patients, even though they get a cephalosporin as their intervention. If we look at the primary outcome now, SDD versus standard of care, the odds ratio and adjusted analysis, you'll see that the mortality goes from 27.9 to 29.5%. That's an odds reduction of 0.94, and you can see it does not quite reach statistical significance. So a non-significant reduction in mortality. For the secondary ICU outcomes, we showed a trend towards reduction in all the days free of ICU, etc., but the days free of ICU is lower, and the rest are not significantly lower as we look through these various measures of exposure to interventions. We looked at our subgroups, and the subgroups are not different between the geographical region, age, sex, trauma status, Apache 2, and the only one that's different is this post hoc, and it came post hoc because a secondary analysis from another trial pointed in this direction, is people with acute brain injury, which is stroke, TBI, subarachnoid hemorrhage, hypoxic encephalopathy, significantly lower mortality. When we look at our infection outcomes, SDD is non-significantly reduced. And you all told me that the cephalosporin was going to cause massive problems with Clostridia. It actually reduces it not quite significantly, but the meta-analysis shows it does. The blood organisms are down significantly, 1.3% absolute, but that's a big relative risk reduction. And any ARO cultures are down by 10%. a 10% reduction in the AROs for these patients. I'm not going to take you through all of this, but similar amounts had cultures. That was left up to the clinical team. But look what it does to gram-positives. Not much, but it does significantly reduce the growth of gram-negatives, as you would expect. That's what it says it's going to do on the tin. This is complex. This is the ecology. This is people who are not in the ICU. Sorry, they're not in the trial, but are in the ICU. And this is how they change from one group to the other as the cluster moves. So we're looking at changes with time for bloodstream infection, for antibiotic-resistant organisms, AROs, and for C. diff. So this is the forest plot. I'll take you through it. We said a non-inferiority margin of 2%. That's very conservative. It's a very small change we're looking here for here. And what do we show? That for new bloodstream infection, there's a reduction that's significant, and indeed, it's superior and non-inferior in the first period and non-inferior in the second. So this is in patients who are not getting SDD in the same unit. For new antibiotic resistance, there's a reduction, but a wide confidence interval. And for Clostridia difficile, it's non-inferior. When we do a Bayesian analysis of this, you see from the initial Bayesian analysis we did a few years ago for the early part of the trial, a 99% chance that this is associated with a mortality reduction when you include all the evidence. We added in the new results from SuDDICU into this, and it stayed at about 99%. And the relative risk is 9% for mortality, which is about 2.5% absolute risk. That's across 38 trials. When I look more detail in a second meta-analysis we're doing, SDD reduces hospital mortality, an NNT of less than 50. It reduces ventilation, and it may reduce hospital length of stay. It reduces bacteremia, VAP, ARO cultures, therapeutic antibiotic use. Look at these NNTs. I mean, that's an NNT of 4 to actually reduce how much therapeutic antibiotic. This is meropenem and piptazo, remember. This is an ICU. And it may not increase, which is the wording of guidelines, MRSA, VRE, and C. diff. But in fact, it looks like it's trending towards a reduction in C. diff. At the unit level, people who are not receiving STD in the same unit may have less VAP, they may have less gram-negative bacteremia, and there is no apparent ecological harm. C. diff, MRSA, VRE, colistin, bloodstream infections, or gram-negative resistance. There's just not a signal here at all for harm, nothing. So when we confront the reality of this evidence, we'll say the evidence base is mature, for sure. It's been around a long time. The effectiveness evidence is for 30,000 patients, and the ecology evidence is from 300,000 patients. So this is mature. A treatment effect will not be more refined by recruiting more patients. So you told me 15 years ago, go away and do this massive trial. You're really just trying to get rid of me, I know. And I stuck at it, and this is not going to be changed now by further randomized trials in areas with resistance rates of low to medium like Canada and Australia are. So massive amounts of patients, very unlikely that this will change. And the sequential analysis shows the mortality benefit's been there since the early stage, and it's maintained, even in the more modern era, with higher rates of antibiotic resistance. We'll never do the perfect ecological study, but we've given you 10,700 patients here who've been in the units of people who've had SDD. If you ask for more than that, it may be unrealistic, if I'm honest with you. The mechanisms of action, I'm just going to postulate here, and it might make your head explode, but that's okay. The IV component is important here. The mortality reduction didn't appear until the IV component was given. But I believe there is a small mortality reduction with the enteral and a small with the IV, and combined, they combine to give us a mortality reduction. I think the IV mops up the early bacteremias because I stick central lines in, I tube them, I do whatever I do, surgical at the time they're coming into ICU. I think the IV is definitely important. But I think the gut component, although delivered from the beginning, is the thing that's actually wiping out these aerobic gram-negative bacteria so they don't translocate, they don't cause bacteremia, they don't grow, overgrow, and they don't develop antibiotic resistance because your anaerobes are preserved. And I think these things are interacting. But there's no way this is just due to the IV antibiotic, is my belief. Now, I know what you're all saying, and you didn't even mention this word when I talked to you 15 years ago. What about the microbiome? Well, I think this is actually very, very relevant, and unfortunately we didn't get funded during COVID to do the microbiome work we want to do, so it still needs done. Yes, there's dysbiosis in critical illness, worse if you're septic, for sure. And we usually give parenteral broad-spectrum anti-aerobe and anti-anaerobic antibiotics like piptazo and meropenem, and we wipe out their microbiome. And I believe that if you give prophylactic antibiotics that only kill aerobes, that by preserving the anaerobes, your dysbiosis is not as severe, and therefore you're able to maintain a healthier but not healthy gut and prevent the overgrowth of these aerobic gram-negatives. So I think it might be benefiting an already sick microbiome, or at least harming it less. And remember, we're giving less therapeutic antibiotics here. That's got to be important. If I think about the timelines here, because I know the second thing you like to say is, this won't last. And it might not, but I couldn't get funded to do 5 years of follow-up when I tried to get funded at the beginning of the trial. So I had to only do it within the trial. So I've got about 2 years of follow-up within this. And so I thought, and you thought, that antibiotic resistance would go up and we would be playing off the patient-centered benefit versus the ecological harm. And it would look like that over time. Your resistance would go up. But in fact, it does that. Now, what I don't know is it going to stay down? Is it going to rise an intermediate level? Or is it going to go back up? And it's easy to say, oh, it's going to go back up. But this seems to work, and it does things that are good to the microbiome, not just of the patients I give it to, but to the patients in the next bed. I mean, that's, to me, is outstanding and amazing to think. So I don't know where this is going to go, but I think there's enough evidence now to say, despite your very, very justified fears about giving more antibiotic, this saves lives. And I know you're worried about the C. diff patients, the CF patients who need colistin now and again. But I'm talking about 10 to 20,000 ICU patients a year in Canada whose life could be saved by this. And then we need to watch antibiotic resistance with even more attention than we ever have. Because we should be anyway. We should use this as a tool to leverage that so that we can indeed implement this and watch what it does in practice. I'm talking about rational antibiotic use, not rationing. Rationing is simply limiting all antibiotics. It's limiting unnecessary antibiotics for sure, but you know, let's focus on some of the bigger pictures you know a lot more about the misuse of antibiotics, and it's not very commonly in my ICU, partly because you and your teams come round every day and we get on very well and we speak and we agree and we limit our antibiotics. But we shouldn't be rationing this in the same way as the trial that Nick did for us last year in New England says we can only give 7 days for bacteremia. That's rational. It's also rational to stop people dying from hospital-acquired infections. And this SDD offers us that. And right now the evidence is strong that we will not be putting up antibiotic resistance, at least in the medium term. So let's be truly rational and not just ration. And it's time, I think, to face up to the fact that we actually need to implement SDD. In critically ill ventilated patients, in summary, SDD compared to standard care didn't significantly reduce in-hospital mortality in this trial, but it's underpowered because the treatment affects 2.5% and we're powered at 3.5%, and further trials will not change this. That's where the effect is. No one's going to do another 10,000 patient RCT here. This is bigger evidence than we have for almost anything we do in our practice. The meta-analysis is clear. Bacteremia and ARO rates are down to an extent that should make your mouth water with what you do. And it's not increasing antibiotic usage, it's actually reducing it. And particularly, it's reducing the piptazo and the meropenem at the expense of giving a cephalosporin. But I can't see the harm that we all thought was going to be there. So it's time to cautiously implement. And that's everything I have to say. Thank you very much for listening.
Thanks, Brian. Does anybody have questions? Counter-arguments? Seems like Brian's ready to take on any counter-arguments.
I might be.
I'm sure people will find you at lunch. Okay, great. Thanks, Brian.
Here's somebody.
So why are people not implementing it or using it?
Yeah, indeed. Well, where's your accent, sir?
Now, it has the same root as your accent.
Well,
but,
if you're going back to Viking times, yeah.
Yeah, exactly. Yeah. So
Are you from the Netherlands?
Sorry?
Are you from the Netherlands?
Exactly.
I thought so. So these clever Dutch people do this. They're either very, very clever or very, very stupid. And I'm going for clever.
I'll leave the judgment on that to the whole crowd.
I think it's fair to say that although everyone thinks the Dutch have been doing this in all centres for many, many years, they've actually only been doing it systematically with kind of national guidance over the last 10 to 15 years. And they have the lowest rate of antibiotic-resistant organisms in the Western world. That may not be a coincidence. They certainly haven't driven it by using SDD, and they believe strongly in it, and they don't do it exactly. We did it the way you have to do it in a trial. They say they modify the ingredients, they add gram-positives, they will rotate, they will stop, they will add double doses, all sorts of things. I can't do that in a trial. So this might be SDD light by the Dutch standard. But so nobody else does this, nobody else does it. And why? Because they're justifiably scared of antibiotic resistance. Justifiably. And I invited every high-powered ID micro person I knew in Canada, and indeed in the UK, Australia, and that, to come on board with this and sit, and I said to them, come and watch me. Come and watch what we're doing here, because I want you to be able to go out at the end and be a disciple and say, I saw it, I seen what they've done, this is kosher. The worry is absolute genuine, and now we have contemporary evidence in area with medium antibiotic resistance that not only does this improve mortality and clinical outcomes, but it actually reduces antibiotic resistance. So it's time now, if not now, when? The evidence will not get any better and get any bigger. And yes, it's a concern. Yes, it's going to give you sleepless nights with the jobs that you people do. And we will never stop worrying about this. But we can't allow 10 to 20,000 Canadians to die a year from this when the evidence is so clear from such a large and highly rigorous trial.
But still.
But still.
Yeah. Oh gosh, you're mimicking my accent. So still, you know, I've learned from being a father, you know, I can beat my children up so that they do something. Yeah, but they still won't do it.
Yeah, I know that one.
I never did that, by the way. Yeah, I never beat my children. Yeah. But or with my farmers, I'm a veterinarian. Or other veterinarians telling them, hey, hello, yeah, why not? That you still need to convince them. Yeah. So have you spoken with communication expert or whatever, or found out what the heck is stopping them?
Yeah, great question. So we did, I showed you just in very brief because there wasn't time, the what, the whether, how and why and that. We did extensive pre-trial knowledge translation here, and we did international Delphis and surveys with ID, microbiology, ICU, pharmacy, critical care, etc., to understand what the issues and the blockages were. And it was exactly that. It was, look, I don't think this evidence is that contemporary, but I really worry about antibiotic resistance, and you've not convinced me yet. People said this is going to be a very difficult trial to do. It was extraordinarily difficult. I'm only 25, and look what's happened to me. I had dark hair when I started this. So listen, I'm joking, but I'm absolutely serious that you guys are absolutely right to be worried about this, but I believe that I've done what I said. I've gone off, I've given you a massive trial, international trial, in intermediate antibiotics. This doesn't mean you can do this in India and Brazil, by the way. I think the only place where further RCTs are warranted is high endemic resistance zones. But here's a hypothesis. If this does work the way I said it does, maybe we should be doing this in high resistance areas. Maybe this reduces antibiotic resistance by stopping these gram-negative aerobes from going wild. So there's a damn good hypothesis which need to be tested that we should be doing this in higher resistance areas, but we need a prospective trial there. I'm speaking to the Brazilians about this, whether we can do it. We tried to include Brazil in the first version of this trial.
Good luck.
Listen, I'm only 25. I've got years to work on this. I can't really have silenced them.
Great. Thanks so much.
Thank you very much.
Very nice.